If you have ever left a physiotherapy appointment nodding along to words you did not fully understand, you are not alone, and it is worth changing that. Understanding the language your clinician uses is not just a nicety, it changes how well you follow your plan, how accurately you describe what you are feeling, and how confidently you make decisions about your own care. Let me walk you through the ones that come up most often and cause the most confusion. The first is inflammation versus pain. People use these words interchangeably, but they mean very different things clinically. Inflammation is a specific biological process. Tissue becomes red, warm, swollen, and tender because immune cells have flooded the area to begin repair. True inflammation is most prominent in the first few days after an acute injury, and it gradually settles as healing progresses. Pain, on the other hand, is an output of the nervous system, a signal produced by the brain in response to perceived threat. Pain can persist long after inflammation has completely settled, driven by a sensitized nervous system rather than ongoing tissue damage. This matters enormously because the treatments for active inflammation and for persistent sensitized pain are very different. Applying heat to genuine acute inflammation makes it worse. Aggressively loading a sensitized nervous system without addressing the sensitization first also tends to backfire. Knowing whether your pain is inflammatory or sensitized tells your physiotherapist what to prioritize. The second is acute versus chronic. Acute simply means recent, typically within the first 6 weeks of an injury or flare. Chronic means persisting beyond 12 weeks. Neither word says anything about severity. A chronic pain can be mild and manageable, and an acute injury can be extremely severe. Your treatment approach changes depending on which stage you are in, which is why your clinician asks how long you have had the problem at the very beginning. The third is mobility versus stability. Mobility is range of motion, how far a joint can move. Stability is control, how well the muscles and nervous system control that movement throughout its range. They often pull in opposite directions. A hypermobile shoulder, one with a very large range, frequently lacks the stability to control that range and is therefore prone to injury. A very stiff lumbar spine may lack the mobility to bend forward, but actually needs stability training just as much, because stiffness in one segment often forces the adjacent segments to move too much. The fourth is active versus passive treatment, which I have discussed elsewhere, but in brief, passive means done to you, active means done by you. The fifth word is tendinopathy, because you will hear this when tendons are involved, and it often replaces the older term tendinitis. Tendinitis literally means tendon inflammation, but research showed that most painful tendons in chronic conditions have very little actual inflammation. They have structural change in the tendon tissue, driven by mechanical overloading over time, without the inflammatory response you would expect in an acute injury. Tendinopathy is the broader, more accurate term for that process, and the treatment is graded loading of the tendon, which sounds counterintuitive but is exactly what the evidence supports. The sixth is range of motion, which gets divided into active and passive. Active range is how far you can move a joint yourself. Passive range is how far the physiotherapist can move it when you are fully relaxed. The gap between the two tells your clinician a great deal. A large gap suggests muscle weakness or inhibition is the limiting factor rather than joint stiffness itself. The seventh is referred pain. This is pain felt at a location distant from its actual source. The best known example is sciatica, where irritation of the sciatic nerve root in the lower back produces pain running down the buttock, thigh, and into the lower leg. The pain is in the leg, but treating only the leg will get you nowhere, because the cause is in the spine. Understanding referred pain changes your whole approach to tracking down the real problem. Being informed is not just more comfortable, it makes you a more effective participant in your own recovery, and that matters more than most people realize. It simply means the treatment needs to be matched to where the problem actually is. The glossary page linked below covers these and many more, explained in plain language without the jargon buried inside the definitions. It is the resource to bookmark before your next appointment, so you can follow everything being said to you, ask better questions, and understand exactly why your treatment is designed the way it is.